Hello. We are back and we are doing another video. Today we're going to talk about gout. How do you manage gout in kidney disease? That's a major question that I get asked. As a nephrologist, I've been practicing nephrology for about 20 years, and so this question comes up a lot. So I want to just dive right in and talk about it. What is gout? Gout is a inflammatory condition where you either have too much uric acid you're producing, or you're not eliminating enough uric acid in your urine. Either way, that extra uric acid sits in your joints and it causes inflammation and it hurts. My dad had gout and he said that it was so painful that he couldn't stand for the cover to even touch his big toe. That's how painful it was. And some of you primary providers who take care of patients, you know it hurts. And patients are basically just out of sorts because it hurts so much. So how do we manage acute gout in chronic kidney disease patients? The big picture at the outset is you can't really give them a lot of NSAIDs. If they have normal renal function, I use indomethacin, ibuprofen, Aleve, that type thing. But if their GFR is compromised, you want to look at using colchicine for an acute gout flare-up. It's a great drug. It's approved for acute gout and also gout maintenance therapy. So you can give it to them every 2 or 3 hours for a severe gout attack. And then once it resolves, you can give it to them twice a day for maintenance of gout to keep them from hurting. Typically what we do is we'll give them 0.6 milligrams. I'll tell them to take it every 4 hours, PRN. And I'll also treat them with prednisone. Because I can't give them NSAIDs, I give them steroidal anti-inflammatory agents. We can't give them non-steroidal, we'll give them steroidal. Prednisone, salumedrol, triamcinolone, oral, IV, IM, or even intra-articular. So the steroidal anti-inflammatory agents, the corticosteroids, those drugs are great for gout patients when they have an acute flare-up. Another drug that I'll use opioids. Gout is an acute pain condition, so opioids are great for acute pain. Chronic pain, not so much because you can get addicted. But acute pain, the incidence of getting addicted to opioids is very low for an acute pain, such as gout or any other type of pain. So we give colchicine, we give steroids, we give opioids. Sometimes we also give pain creams, such as your aspirin cream or nonsteroidal anti-inflammatory agents. We can give some of your compounding creams are really good. So that's another thing that we'll use sometimes in our patient population. And the big thing is diet. I tell a lot of patients that, the high fructose corn syrup, foods and drinks, sodas, those chemicals in those foods metabolizes to uric acid. And so a lot of people just don't know that. So when you got a patient who continue to have gout and they continue to just really have recurrent gout flare-ups, you want to look at their diet and you want to recommend a low purine diet, which is really, cutting back on red meats and seafoods because those meats get metabolized into uric acid, but also fructose corn syrup that will get metabolized into uric acid. So, just do a dietary analysis on your patients and just see what they're eating, or at least give them a framework of a gout diet that they can do. So once you get the acute gout flare-up resolved, before I go on, I want to tell you about my course. We have a free webinar below you can check out. We have a 7-module course with quizzes after each module, and we're basically talking about all the things that you will see as a permanent provider in your clinic with chronic kidney disease. This class is like a mini fellowship, and I'm trying to teach people how to do what we nephrologists do in clinic. A lot of nephrologists are getting old and retiring, and somebody's got to take care of these patients. I know I don't look old, but Somebody got to take care of these patients. So, chronic gout. After the acute gout flares resolves and your patient's pain free, what do you do next? Well, you look at trying to treat the acute gout attack by checking uric acid levels and putting the patient on either allopurinol or febuxostat. The other name for that is Uloric. So these agents can lower uric acid levels. Allopurinol is really good for all patients. It's pretty well tolerated. But in CKD, the febuxostat, the other name for it is Uloric, has a better side effect profile for CKD patients. That's why I like to use that agent. And a little bit more uric acid lowering effect. So I want to encourage you to use Uloric in your CKD patients instead of allopurinol. I don't see a lot of major side effects with the allopurinol unless you ramp the dose up really high, but the Uloric is actually better tolerated in CKD. So those are the two main agents that we use in our clinic for chronic gout. And also, some people in the past, we used to use probenecid, which is another uric uricosuric drug, sulfentrazone. There was another uric uricosuric drug. These drugs enhance the urine production or urine excretion of uric acid. They're weak organic acids, and they increase the renal clearance of uric acid. So that's the probenecid and sulfentrazone. Those are two that you can use. Benzbromarone is another one. I've never used that, hardly ever, but that's another one that people use. Uricase, that's urate oxidase. This is a drug enzyme that catalyzes the oxidation of uric acid to allantoin, which is the soluble form of uric acid. So that's another agent you can use. It's approved to treat hyperuricemia. A lot of our cancer doctors will use uricase because some people can get tumor lysis syndrome and their uric acid levels can go up really high. So they'll put them on this to help basically break all that uric acid down to the soluble form of uric acid, which is allantoin. So that's another thing that we can do to treat acute gout. Just checking out my slides here. Gout is somewhat challenging to treat in CKD. So I want to encourage you to try to stay away from your nonsteroidal anti-inflammatory agents and lean heavily on your colchicine, your corticosteroids, your opioids, and your other alternative agents for pain or inflammation. And most patients, I've never had a patient that I could not get pain free if they had a gout attack. Many patients' problem is they're eating the wrong food. You're the doctor, you're trying your best to treat their gout and to treat their pain, and they going to eating all red meat, the shrimp, the seafood, and drinking sodas. So they're adding insult to injury and basically being counterproductive with what you're trying to do as a provider. So always look at diet. I want to encourage you as a primary provider, you're on the front lines for these CKD patients, and we want you to be totally adept and totally competent in managing all these little things that come up in your clinic. Check us out below. We have a community that you can sign up with. We have a free webinar that you can sign up below. I would love to hear questions from you all about this video, and I hope to see you in the next video. We have a lot of videos on the things that you'll see in clinic, so check us out. We will see you in the next video. Thank you.